Good evening, everyone. I'm Tony Segreto, the moderator for tonight's In the Know Town Hall. We welcome you all to another important exchange with world-renowned Sylvester Comprehensive Cancer Center patients, experts. Tonight, we will focus on devastating disease that affects more than 64,000 people in the United States, pancreatic cancer. With a 5-year survival rate of 12%, pancreatic cancer is projected to become the second leading cause of cancer death by the end of the decade. Thankfully, we have an incredible team of Sylvester physicians and researchers who are working tirelessly towards a day when pancreatic cancer is more manageable and even curable. Before we launch into tonight's town hall, let's go over how you can participate in tonight's conversations. After our opening remarks, the panelists will answer questions that you submitted over the last few days. You can also submit the questions during the program. Please use the Q&A feature. You see it at the bottom of your screen there, and then you can send it in to us. Remember, the questions are submitted anonymously, and we will get to as many of them as we possibly can. Now, it is my pleasure to introduce a giant in the field of cancer research, Dr. Stephen Neimer, Director of Sylvester Comprehensive Cancer Center. Dr. Neimer is also the Oscar de la Renta Endowed Chair in Cancer Research and the Executive Dean for Research at the Miller School of Medicine. Dr. Neimer, we welcome you.
Thank you so much, Tony, and good evening, everybody. We indeed have an esteemed group of experts who are taking Sylvester to new heights in terms of breast cancer research and patient care. As Tony mentioned, pancreatic cancer is a devastating diagnosis. November is actually Pancreas Cancer Awareness Month, but we have research going on every day trying to identify new ways to treat this disease, and we've made some significant advances, and these advances have occurred based on multidisciplinary approaches, based on medical oncologists, radiation oncologists, and surgeons working together to make advances against this incredibly complex disease. Tonight, we have three of our leaders in the field, incredibly dedicated experts who are focused on finding new treatments and cures for this disease. You will hear from Dr. Nipun Merchant, who holds the Alan Livingston Endowed Chair in Surgical Oncology. He's chief of the Division of Surgical Oncology at UHealth and a vital member of the Cancer Center. He will bring his expertise as the director of Sylvester's Pancreas Cancer Research Institute. He's also chief of the vice chair of Surgical Oncology Services and one of the co-leaders of the GI Cancer Site Disease Group. Also joining tonight is Dr. Peter Hossain. He's the associate director for clinical research at the Sylvester Pancreas Cancer Research Institute, and he's a co-leader of the GI Cancer Site Disease Group. He's an associate professor of clinical medicine at the Miller School of Medicine. And we also have Dr. Lorraine Portalance, who's vice chair and clinic division chief of Radiation Oncology Department, and also a co-leader of the GI Cancer Site Disease Group at Sylvester, and she's a professor at the Miller School of Medicine. These are esteemed colleagues who work together to explore new treatment options for patients with pancreas cancer and try to understand why the treatments work in some and not in others, and how to develop a better understanding of the biology of this disease. Their mission is made easier, I would say, by the creation of the Sylvester Pancreas Cancer Research Institute, which is committed to reducing and eliminating the human burden from pancreas cancer. A lot of other, Dr. Dada and others are here at the Pancreas Cancer Research Institute and are contributing from a research point of view. And so we have teams behind the physicians who you see here tonight that are working together. And with generous support from our donors, we're able to speed up things, explore new ideas, and hopefully provide longer and healthier lives for the people who are surviving pancreas cancer. We have a number of individuals who call themselves living proof that we've made strides against this disease. and these are 10 and longer year survivors of pancreas cancer. So Tony, I'll turn things back over to you. Thank you so much. You always do an incredible job working with us on these in the knows. So Tony, it's yours.
Thank you, Dr. Neimer. It's a pleasure. Okay, Dr. Marchant, are there any ideas why this once rare cancer has rapidly become more prevalent in the past 40 years?
Yeah, so thank you, Tony. I'd just like to say a few words as we start. It's really a pleasure to be here this evening. My colleagues, Dr. Portelance and Hussein, are eager to answer many of your questions and share a lot of the advances that we're making in pancreas cancer. As has been mentioned, pancreas cancer is a very devastating disease, as you all know. And while we've achieved a lot of significant advances, pancreas cancer still remains one of the hardest cancers to treat. We really don't have too many early detection mechanisms and is really one of the hardest and most resistant cancers to treat. There are several reasons for that. And in a nutshell, what we haven't been able to do well is target one of the key genes that leads to pancreas cancer. We're just starting to make some progress in that. And the structure of the cancer itself acts as a barrier to drugs able to penetrate the tumor and also patients' immune cells to try to penetrate the tumor and kill the tumor. And although we have a long road ahead, we have made a lot of major breakthroughs that we're excited to talk about tonight. We're seeing incredible outcomes thanks to the expertise and dedicated of my fellow panelists and so many others here at Sylvester. In addition to all of that, as we go into the questions, I want to thank all of you for who have supported our work. While we continue to increase our research funding in pancreas cancer, philanthropy really is important and ensures that we can continue to push on the breakthrough research and deliver the best treatment options. All of you inspire us to go above and beyond and find solutions that are going to make a difference in our patients' lives and the impact that we can have in the community here in South Florida, as well as the nation overall. So thank you all for your generosity. You asked Tony about why the prevalence of pancreas cancer is increasing in the last 40 years. And it's true that although it's not one of the most common cancers, as you said, it's going to become the second leading cause of cancer death in this country. And it's one of the few cancers where incidence still is continuing to rise. There are several reasons for that. Most of them are likely environmental, and we don't fully understand all of the reasons, but smoking is a big risk factor for pancreas cancer. And with the use of tobacco, that continues to increase the risk of pancreas cancer. Obesity is also another risk factor for pancreas cancer. And with our obesity epidemic in this country, that's probably another reason why you're seeing an increase in certain cancers that are obesity related, like pancreas cancer, breast cancer, colon cancer, amongst others. And then there's starting to see some links between diabetes, especially when diabetes forms at a much later age in life. Those are other risk factors, and those are all the factors that are very prevalent in our society today that are lead to the increase in the incidence.
Doctor, thank you. Dr. Hussein, can a person sense what there is something wrong with them and with their pancreas, or are there any early warning signs to be alert for? And are there any recent early detection tests for it?
Yeah, thank you very much, Tony, and good evening, everyone. I see we're up to 111 participants in this webinar right now. Thank you all for joining. I see some familiar names in the audience. So great question, Tony. So unfortunately, because of where the pancreas is located, there are really very few symptoms of something wrong with the pancreas until the problem is relatively advanced. So pain is the most common symptom. If you have a tumor, for example, growing in the pancreas, sometimes if a tumor is growing in the head of the pancreas, you can develop what we refer to as jaundice, where the bile drainage is obstructed, and you can have a yellow discoloration of the skin. And that's one way of knowing that something could be wrong with the pancreas. Very subtle signs, such as the development of diabetes or high blood sugars in a patient who is not obese and who doesn't have a predilection in the family for diabetes, could be a warning sign that something is going wrong as well. And then very non-specific symptoms like indigestion, gas, bloating could also signify that there's some deficiency of enzyme production from the pancreas. In terms of early detection tests, we do not have a screening test yet that can be applied to the entire population, the same way that we screen for breast cancer with mammograms and we screen for colon cancer with colonoscopies. We do not have a test available yet. However, in people who have a strong family history of pancreatic cancer, or if there's a genetic syndrome in your family, such as an inherited BRCA mutation, these patients are offered screening. And in fact, we have a protocol right now open at Sylvester where we're offering screening tests such as MRI scans and endoscopic ultrasound to these patients who are considered to be at high risk. And in fact, if we can detect cancer at an early stage, the survival goes way up, in some series as high as 80% 5-year survival, which is substantial in this disease where the survival rates are much lower than that. So that's where we stand right now. Do not have a early detection test for everyone, but for individuals at high risk, we can offer screening.
Doctor, thank you. Dr. Merchant, are there any genetic testing and screening for pancreatic cancer? And what genetic testing or screening do you recommend if someone has a family history of pancreatic cancer?
Yeah, so again, as Dr. Hussain said, we don't have any early screening detection markers, and primarily that's because precursor lesions to pancreas cancer, meaning lesions that occur before cancer develops, you can't see. Like in colon cancer, you do a colonoscopy, there's a polyp and you can see it, it's precancerous, so you can remove it, and we know that. In breast cancer, you get a mammogram, there's changes on mammogram, calcifications, other things they can see before it becomes a cancer. In pancreas cancer, the precursor lesions are not visualizable by any imaging technique. So that becomes a problem. The genetic tests, as Dr. Hussain mentioned, there are few genetic mutations that we know of as the BRCA mutation that many people are very familiar with that is high risk for people developing breast and ovarian cancer, while patients are also at high risk of developing pancreas cancer. So certain mutations, if we know, we do put them on a screening program. We have a very robust screening program here. We're part of an international consortium really looking at trying to identify early detection biomarkers for pancreas cancer. But unfortunately, these mutations occur in only about 5 to 7% of all patients with pancreas cancer.
Thank you, Doctor. Dr. Portelance, welcome. What is the role of radiation therapy in the management of pancreas cancer?
Well, this is a very good question. So most patients who are diagnosed with pancreatic cancer have, unfortunately, a disease which is more locally advanced when it is diagnosed and are past the level where a simple surgery done up front would be taking care of their problem. So the first thing for those patients is definitely to see Dr. Hussain and his colleagues and be started on a good treatment of chemotherapy, both to reduce their tumor and also to prevent the risk of developing disease outside of the pancreas. But what's happening is once that first chapter is completed, or once we've reached a maximum response with Dr. Hussain's chemotherapy, we are still dealing with a local disease that needs to be taken care of, and often still not resectable because the place where this pancreatic tumor is localized is adjacent to important blood vessels in the abdomen, and resecting the tumor would involve blood vessels reconstruction, which often is impossible to do. So then here comes the role of radiation therapy. So for patients with locally advanced pancreatic cancer, we could step in with, very precise way of delivering radiation so that we could deliver a high dose to the primary tumor, shrink further the tumor, often help with symptoms control, and provide our patients with many, many months of local control. We could also help patients who are unfortunately further in the spectrum of their disease when we reach a point where the disease has spread to other organs and there's a need for palliative radiation therapy.
Thank you, Doctor. Dr. Marchant, what clinical trials are you currently running?
We actually have numerous clinical trials, and I think Dr. Hussain would be better able to speak to those.
Sure, thanks, Nipun. So we try to have clinical trials for every stage of the disease and also every line of treatment. So patients go through first line, second line, and it's often complex to open studies here, but we have trials including radiation trials for patients with localized disease, and there's some innovative trials that we've participated in here that have led to a wider acceptance of things like MRI-guided radiation. And then for patients with advanced disease who are not candidates for surgery or radiation therapy, we have trials which include chemotherapy and sometimes immunotherapy. So we have currently a trial for patients who are newly diagnosed with advanced disease. So this is a trial which is sponsored by PanCAN, the Pancreatic Cancer Action Network. And it's a consortium of some of the top pancreas centers in the country, including chemotherapy plus some immunotherapy strategies, that is available for patients with first line and second line. I saw there was another question about phase 3 trials. That is a phase 3 trial. And then later down the line, we have some trials which we have developed in-house. Dr. Merchant's lab has been investigating different strategies for targeting that KRAS mutation, which affects about 90% of people with pancreas cancer. And we have developed a clinical trial, which is run only at Sylvester, combining agents targeting KRAS with immunotherapy. And we have a few patients enrolled in that study. Unfortunately, we have to go very slowly when we have innovative studies like that, because we have to make sure that it's safe to treat patients with those novel combinations. So we usually open the door and enter 1 or 2 patients, monitor them, and then add more patients as we go along. So we're also bringing additional trials testing novel types of immune treatments, such as CAR T-cell therapy. There was another question about CAR T-cell treatments, which involve essentially extracting T cells from the patient, modifying them, and reinfusing them to the patient after the cells have been educated to recognize a specific target. So there's a wide range of studies that we are conducting right now. Now, the reality is that it's sometimes difficult to find an appropriate clinical trial, and we help to guide patients in that regard. And we always are trying. We have a few studies in the pipeline. So our goal really over the next few months is to have a clinical trial option for every single patient who comes through the door.
Yeah, and what I'd like to add to that also is, in addition to having a trial for every patient with pancreas cancer, we also have trials in patients with precursor lesions that before the cancer develops, in an effort to identify early biomarkers of detection in many of these patients. So our goal here is to have clinical trials available for every spectrum of disease, from before cancer to very advanced cancer.
Thank you. Dr. Marchant, are there any gene or stem cell therapies being used or tested now?
Currently, there's no specific gene therapy being tested for pancreas cancer. As Dr. Hussain mentioned, CAR T therapy is starting to be developed. It's difficult sometimes the way CAR T therapies work. There's not a specific antigen in pancreas cancer that's been identified that we can target specific to that cancer. But as we learn more about the whole microenvironment in pancreas cancer, these type of therapies are starting to be developed now, but they're in very early stages.
Dr. Portelance, what are the risks of a treated colon cancer appearing as pancreatic cancer?
Oh, that's a good question. So first thing that is important to know is that when a mass is discovered into the pancreas, 95% of those tumors are really tumor originating in the pancreas, as opposed to, for example, if we find a lesion in the liver, where we could find a large percentage of these being metastasis. So only 5% of the tumor found in the pancreas will be a metastasis, meaning it's going to come from cancer cells from a tumor from somewhere else in the body. And among these, yes, colon cancer is one of the primary, and the other the other primary which could metastasize to the pancreas will be renal cell cancer or GYN cancer. So very rarely it could happen, but yes, it is possible. And hence the importance of, doing a biopsy for a mass found in the pancreas in order to confirm the diagnosis and guide treatment.
Thank you. Thank you, Dr. Hussain. What are the new therapies in treatment and in immunotherapy as well?
So right now, there are many different groups studying different strategies. And if you ask me, what is the treatment which is likely to be the next breakthrough in pancreatic cancer? It's really drugs targeting this KRAS mutation, because we've known for decades that the KRAS mutation is present in 90% of people with pancreatic cancer. And so far, we've only been successful in finding targets or finding treatments that can target very few of those mutations. So, for example, there's a mutation, a KRAS mutation called G12D, D as in David, and there have now been drugs in clinical trials that are targeting this mutation. So that is the next frontier, but the likely next set of treatments that would be approved for pancreas cancer. Now, because of the success of immunotherapy in other malignancies, we've been trying different strategies of making pancreas cancers more responsive to immunotherapy. So the trial that I mentioned before is one strategy, and there are many groups investigating other strategies. And in fact, we have seen some patients with pancreas cancer respond incredibly to immunotherapy, but we believe that there are some genetic biomarkers, such as BRCA mutations, microsatellite instability, that allow those patients to respond to immunotherapy. So the two main groups of treatments which are being investigated most frequently right now include treatments targeting KRAS and then novel immunotherapy combinations.
Thank you, Doctor. Dr. Merchant, any way besides scans can you tell pancreatic cancer is returning or coming back, like lab test levels?
So that's a great question. So once the tumor is out, there are many things that we follow to try to detect any evidence of recurrence early. Scans are obviously the primary way that we can actually visualize the tumor, but there are certain tumor markers that we follow, one of them being CA19-9. It's a specific tumor marker for pancreas cancer. And although it's a good tumor marker in some patients, it's not 100% reliable. And the reason for that is about 15 to 20% of patients don't make the antigen that promotes CA19-9 in the blood. So 20% of people, even with widespread cancer, will have no level of that blood test. The other thing is, other things other than pancreas cancer can also make the CA19-9 levels go up. Just jaundice in and of itself, or any inflammation in the bile ducts or anything, can make that level go up. So it's not always 100% accurate. Where it is helpful is If it was elevated at the time of diagnosis, and then we treat the patient and we see levels coming down, and after surgery, the levels come way down. And if we start seeing it go back up, that's also an early detection marker that we use in addition to scans and imaging. What is on the forefront now is we're now able to detect actual cancer cells in the blood, other than just biomarkers. And so that's a big area of study for us, for pancreas cancer. In colon cancer, it's already seems as though it's a very viable aspect to look for early detection for recurrence, looking for specific colon cancer cells in the blood. In pancreas, we're doing a lot of research on this. Other institutions are also, but in the future, I think we'll be able to identify actual cancer cells in the blood as early detection biomarkers well before we can see it on scans.
Thank you, Doctor. Dr. Hossein, what are the best diets to follow?
Mm.
All right, so that's a great question. It's a question that I think I get from every patient on the first visit. So we're very fortunate that we have a dedicated oncology dietitian who works with us in the clinic, who can see patients on the first visit. But you know, there are a lot of patients who believe that they need to go into extreme diets when they're diagnosed with pancreas cancer or any cancer. What we normally recommend are a few general guidelines, including avoiding things with a lot of fat, foods with a lot of fat, because in general, it's a little more difficult to process fat. And many patients, I can see some names here on the webinar, who are taking pancreatic enzymes to be able to digest fat. It's not that it's detrimental for them to ingest fat, but it's a little more difficult for them to digest. So that's one thing that we recommend avoiding. And you know, we supplement the diet with pancreatic enzymes so they get the maximum benefit from the food that they eat. And then diets which are high in processed sugars are also discouraged, because patients with pancreas tumors have a higher chance of developing diabetes if they're not already diabetic. Now, we get a lot of questions about keto diet, intermittent fasting. It's a little bit difficult to make blanket statements about that, because we really don't have, you know, systematic or strong scientific proof. There's some studies that suggest that some of these things could be beneficial, but at this point in time, in fact, there's a clinical trial, a systematic trial ongoing right now, testing the keto diet. So we don't know yet if it's beneficial or not. And there are definitely data out there regarding intermittent fasting, but it's not something that we routinely recommend yet, because I don't think there's systematic clinical data. We are including some dietary endpoints in some of the trials that we're doing. So we hope that we'll have better answers to these questions. But at this point in time, there's some guidelines. Now, the other issue that we have to consider is that many patients with a diagnosis of pancreas cancer tend to have a significant amount of weight loss. So we tend not to have too much calorie restriction, because we don't want to exacerbate that. We want patients to be able to maintain their weight, and that includes using pancreatic enzymes. So there's no one size fits all. I'm very happy that I can call on my dietitian. And for those on the call, if you need help with that, you can reach out to us. That's actually a complimentary service. When patients come through Sylvester, through Cancer Support Services, they can get that access to that expertise.
I think this also highlights, the importance of, coming to a specialized cancer center, because as we see these patients, it's not just about surgery or chemo or radiation therapy. It's about a multidisciplinary team that's seeing the patient, doing genetic testing on everybody's tumor, trying to identify a very specific personalized treatment plan, but also considering all of these other factors that many people kind of ignore, including diet, other social aspects of care, which, can be prolonged for several months or longer, which are very, very important in the whole management of the patient.
Thank you, doctors. Dr. Merchant, I have an umbilical hernia. Considering I had Whipple surgery, will it be a problem to fix the hernia?
That's a very quick answer. There will not be a problem. We can get it fixed at any time.
Okay. Dr. Portland, yes. Could radiation help control the pain caused by the pancreas tumor?
So that's a good question. As mentioned by Peter earlier, like the pain localizing around the stomach and irradiating to the back is a very, very frequent problem that our patients with pancreatic cancer have to deal with. And that pain could be difficult to control with medication, and then it leads to the use of high dose of narcotics, which come with their load of side effects also. So in a situation like this, our team, we care a lot about the quality of life. It's not only about extending life. It's very important to extend life of patients with pancreatic cancer, but we want a life of a good quality. There is a way with radiation therapy to target the area where the tumor of the pancreas is infiltrating into the nerve plexus, which is right behind the tumor, between the tumor and the aorta. And by targeting this area with radiation, we could significantly help to decrease the pain level of our patients and then help them wean down a bit the pain medication they have. What's nice about this approach to the pain from, we call it the celiac plexus, is that it's non-invasive. It doesn't involve a surgery. It doesn't involve a procedure where we would have to go in with probes. It's all happening with a precise way of delivering the radiation, and it could even be done in a single session of treatment.
Thank you, Doctor. What is the latest approved therapy? Advanced stage pancreatic cancer, Dr. Hussein.
So, the treatments that we use, unfortunately, right now are relatively old. The last chemotherapy that was approved was about 10 years ago now. The last approval was for an oral medication called olaparib, which really only applies to less than 10% of people, and those are patients with pancreas cancer associated with a BRCA mutation. So if you have an inherited BRCA mutation, olaparib can be used. And we have some patients, in fact, we participated in the trial that led to the approval of olaparib. And I still have a patient on that trial 6 years out with no evidence of disease, still taking the pill. So that illustrates the importance of clinical trial participation, because when I saw the presentation of that study and they showed the survival curve, I can tell where my patient was on that survival curve, and he's still doing very well. So that was the latest approval. There are actually some drugs which are approved in what we refer to as a tumor agnostic application, meaning that it doesn't matter what the tumor site is or where the tumor came from, but if it has a specific mutation in it, you could get access to the drug. So if you have a pancreas cancer with a RET mutation, RET, there's some drugs approved for that. If there's an NTRK mutation, there's some drugs approved for that, BRAF mutations, etc. So this is the reason why we do genetic profiling on every patient. And this is something that we routinely do on the first visit. We do testing for inherited mutations. We just send a tumor out for profiling. If we don't have enough tumor sample, we can send a blood sample for the circulating tumor DNA that Dr. Merchant was mentioning before. So we really try to get as comprehensive as possible a picture of what is going on with the tumor genetics, and that can open up some treatment options. So even though the menu of options for pancreas cancer is relatively short, when you start opening up the box of tools for genetic alterations, sometimes you can discover new treatment options.
Thank you. Thank you, Doctor. How effective is proton radiation therapy? This is for you, Dr. Borderlands. How effective is proton radiation therapy in reducing the size of pancreatic cysts?
So pancreatic cysts are, it's in fact a benign disorder. And for now, the use of proton beam therapy for benign disease is really not something that, has a lot of data on, and we're not doing this outside of clinical trial. So unfortunately, although proton beam therapy is a wonderful technology that could help a lot of patients because of the way it could precisely deliver the radiation, sparing the surrounding normal tissue, we would not use the technology for cystic lesions, for cysts. Yeah.
My father died of pancreatic cancer at age 55. How can I go about the genetic testing at SCC? Where do I start, Dr. Hossein?
All right, so that's very easy. So we have a high-risk clinic that is run by an outstanding gastroenterologist who runs a GI genetics clinic. His name is Dan Sussman. And it's run in conjunction with a geneticist. And we have this clinical trial called the PROCEED trial that we are trying to encourage people to enroll on if they have a family history. So within that program, even if you don't enroll on the trial, we encourage participation in the trial. But even if you don't, we can do genetic testing through that. And if you call the main line, and we can put the number out there for Sylvester, ask for the GI genetics clinic. They can direct you to make an appointment, and we can do it. It's very easy to do.
Thank you, Doctor. Dr. Merchant, are there particular organs this cancer can metastasize to?
Right. So, one of the things we look at when we see a patient come in for the first time is, the imaging is very, very important. Because many times, I would say almost half the time, the cancer has spread to other areas by the time of diagnosis. There are certain organs that are more common. The most common site of metastasis tends to be the liver, because the blood flow to the pancreas drains right into the liver. So that's very common. But pancreas cancer can spread to the lungs. It can also shed cells from the primary tumor and spread to the lining of the abdomen. Those would be the three most common areas. But it can, in rare circumstances, go to other organs like the bone or the brain also. But the lung, the liver, and the lining of the abdomen are the three most common areas.
Thank you. Dr. Hussein, what new treatments are there without surgery?
We mentioned a few of them already. Patients with non-cancer surgery. Generally, we go through chemotherapy, clinical trials, radiation therapy is an option. And, we have been doing now some combinations with radiation therapy, immunotherapy. So, there are other niche procedures that we can do sometimes. For example, we have some experience doing a procedure called IRE. Dr. Portelance mentioned proton radiation therapy. But in general, the main treatment is some form of systemic therapy, meaning that we need to get some treatment into the patient that can get into the system and target cancer cells wherever they might be. So we try to incorporate localized treatment options such as radiation and other types of innovative treatments as much as possible. But usually we have that on a background of some kind of systemic treatment, which is usually chemotherapy. And we have some patients who do very well, live a very long time. And I tell most of my patients that, all the long-term survivors that we have are patients who have passed through some chemotherapy. So it's not fun to receive chemo, but that's usually what we need to get the disease under control, to give us the opportunity to bring in other innovative options.
And what I'll say is our goal with this obviously is to use these other therapies, chemotherapy, radiation therapy, to be able to try to get the patient to surgery. Because if you really can't remove the tumor, then the chance of curing this is almost impossible.
Thank you, doctors. Dr. Portelance, what is the current prognosis for stage 4? Forgive me if I mispronounce this. Adenocarcinoma pancreatic cancer that has metastatized in the liver.
Well, as mentioned earlier at the beginning of the conference, we did make some progress in the 5-year overall survival of patients with pancreatic cancer. And, in general, it went from, 6% to 12%, which is still too low. And that's why we work so hard together to improve the prognosis. But so that 12% is for the whole, population of patients with pancreatic cancer. And unfortunately, when we cut this down to a subpopulation diagnosed with stage 4 cancer, which is the story when someone has disease spread to the liver already or to the lung at diagnosis, unfortunately for those patients, the 5-year overall survival is only around 5% at best. So there are long-term survivals. I don't want to send the message tonight, it's impossible. And we all put our heart and our heads together to make it happen and to help those patients out of the difficult situation. But there is room for a lot of improvement in the management of those patients diagnosed with stage 4 cancer.
Thank you, Dr.
Let me comment on that if you don't mind, Tony. Sorry to interrupt. So a lot of patients ask that question, and how I look at this, and I think Dr. Portland and Dr. Merchant will agree, is that they're historical statistics that if you go on the internet, you'll find the 5-year survival rate, right? But those numbers are a little bit outdated by the time you read them. And what we try to do is to give every patient the opportunity to be the next outlier, to be the next long-term survivor. And how we do that is by trying to come up with the best individualized plan for that patient. And you leave no stone unturned in terms of looking for treatment options. We have many options here. Sometimes I refer patients out to different centers to get other treatments that are not available here. And if you do that, sometimes you see very successful outcomes, and there's some patients, patients who have done very well. We have some patients who are 10-year survivors and longer. Now, that unfortunately is not the case for every single patient, but what we really try to do is to give every patient the opportunity to be that next long-term survivor. So that's really our approach here.
Yeah, I think let me just add to that also, because this is a very important question, and many people ask it, many people fall into that category. I think the importance here is, as Dr. Hussain had mentioned, that every patient that comes in here, we do a genetic profile of that patient's tumor. And as he mentioned earlier, we now have drugs to many of these mutations. So if we do, and that patient has a specific mutation, then we can target that mutation and the outcomes are even better. And Dr. Hussain is being a little humble, but he was actually one of the first people in the world to describe novel therapy using 2 different immunotherapies in certain patients with certain types of genetic mutations in their tumor. Now, they're not that common in pancreas cancer, but if you do have that mutation, he's been able to show that using 2 different chemotherapy regimens have actually cured many patients with stage 4 cancer that were refractory to every other type of therapy that was tried before. So I'm not saying that that's a cure-all for everybody, but it kind of highlights the importance of coming to a center that uses the latest technologies, genetic screening, profiling, and multidisciplinary teams to really come up with an individualized treatment plan for patients.
Doctors, Dr. Hussain, histotripsy be a solution to kill pancreatic cancer cells? The University of Michigan has used it for liver cancer.
Yeah, so that's a great question. And this has been in the news and a lot of people come across it. So histotripsy is another type of local therapy, right? So remember, I mentioned before that there's systemic therapy, which can target any cancer cell anywhere in the body. And there are local therapies such as surgery, radiation therapy, ablation. Histotripsy falls under that category as well. So it's a technique which it is effective in killing tumors. So if you have one tumor, for example, in the liver, a metastasis from pancreas cancer, a metastasis from colon cancer, you can effectively eradicate a small enough tumor using histotripsy. However, whether that makes a big difference in the overall picture depends on what else is going on in that patient. So if you really only have one tumor and the patient's not a candidate to have a resection or something else, that could be an option. It's so far, we haven't used it systematically in pancreas cancer. It's a relatively new modality. But how I look at that is still the first question you have to ask is whether it makes sense to go after one tumor, whether that will help the patient, right? And if you say yes, it will make sense to do that, then you look at the menu of options: radiation therapy, ablation, histotripsy, IRE. We have a few options to do that. And if depending on the expertise at the institution, sometimes it makes sense, right? So histotripsy is a good tool. It is on the list of things that can be done. But if you have somebody with cancer in multiple different areas, that usually is not enough to control the disease. So you really have to think about not whether it can be done, but whether it will be beneficial in the big picture.
Right. So it's a beautiful
Doctor,
technology,
thank you. Go ahead, Doctor.
and it was FDA approved just, in fact, 2 weeks ago. They received their FDA approval, and it is for now approved for the management of liver lesions. And it is the goal of the company to explore if this type of technology could also be, helping patients with pancreatic cancer and tackle the primary tumor, perhaps with those high energy ultrasound. It is definitely an interesting question, and I'm confident that we will see in the next few years data coming out supporting the use of the technology in the management of pancreatic cancer patients, but it is a field to develop.
Thank you. Dr. Hussein, Dr. Merchant, has there been any improvement in life expectancy in the last few years? And has the survival rate for pancreatic cancers changed in 5 years? Dr. Merchant.
Yeah, so, that's a very commonly asked question and a very important question. What I will say is that we have made amazing and significant strides in the last 5 to 10 years in pancreas cancer. For 30 years prior to that, our 5-year survival rate was stuck at 5% about, which was obviously dismal for any type of disease. In the last 10 years, the survival rate for pancreas cancer has gone from 5% to 12%. And while 12% is not anything to write home about, the fact that we have more than double the survival rate in a short period of time just speaks to the advances and the progress that is being made on such a rapid scale. And I think you're going to continue to see that survival rate continue to increase over the next few years because of our greater understanding of the tumor and the disease, and the novel therapies and clinical trials that are now available at so many centers, and the research that's ongoing at centers like ours that is really advancing, the outcomes in patients.
Thank you, Doctor. Is Dr. Hussein, this is for you. I understand there's work on a pancreatic vaccine. We know about that.
Yeah, that's a great question. So there's a lot of excitement about immunotherapy in general and vaccines in particular, right? So one of the vaccines that is being developed right now is using the same technology that we use to develop the vaccine for COVID-19, which is an mRNA vaccine platform. So that study is in partnership with BioNTech, and is actually looking at patients' tumors and looking for specific fingerprints of what we call neoantigens. So every patient's tumor is different. So in order to develop that vaccine, it's not an off-the-shelf vaccine like the COVID-19 vaccine. this is a vaccine that is created specifically from the patient's tumor. So the tumor is sent out to the company. They create a genetic profile, create some proteins that mimic that those abnormal proteins, and then you inject it into the patient. And what they found in the first trial that was reported last year was that they were able to see immune responses in about half of the patients, and those patients have had benefit in terms of prevention of recurring cancer. It's still at an early stage, and there's a separate vaccine now being developed specifically for the KRAS mutation. So that is more of an off-the-shelf vaccine, meaning that we don't need to know specifically your genetics. Just if you have a KRAS mutation, that second vaccine could be an option. So that is probably easier to commercialize or easier to get to the market. So I would say, so those are in clinical trials right now. Both of them are going into phase 2 trials this year and early next year, and probably a year or two after that, we should see phase 3 trials of these vaccines. So it's one of those trials is coming to Sylvester in the new year, within the first couple of months of the new year, and we actually have a few patients already in the queue waiting for that to open up. So it's an area of very exciting research that we are participating in.
Dr. Hossein, can you talk about prevention of pancreatic cancer?
Sure. So, that is a difficult question. It's a good question. It's a difficult question because prevention implies that you know what causes the cancer, right? So in the majority of patients with pancreas cancer and in many cancers, we don't know exactly what is the triggering factor. So we know that there's some things that increase the risk, as Dr. Merchant mentioned before, cigarette smoking. So if you're a smoker, you should stop smoking, and having a healthy lifestyle in general. But there are people who lead very healthy lifestyles and still develop cancer. So what we try to do is to screen people who we believe are high risk, and we can detect cancers early. So that's one strategy. Now, there is a prevention strategy ongoing right now for people who are at very high risk, especially people with BRCA mutations, where there are some vaccines which are being developed to try to educate the patient's immune system to recognize abnormal cancer proteins and prevent a cancer from developing in the first place. That is still in very early testing. So at this point in time, we give general guidance. So if somebody believes that they're high risk because of family history, they should be screened. And in terms of more specific prevention, we don't have a strategy yet that is really widely available to prevent cancer. But that this is something that is actively being investigated.
Dr. Merchant, do pancreatic cysts become cancerous?
Yes, so that's a great question, and it's something that we frequently encounter. And the reason for that now is that scans are so commonplace in medicine. So you walk into a hospital, you walk into an ER, you're going to get a CAT scan. And many times on the CAT scan, to look for something else, we see patients that are found to have cysts in the pancreas. Now, the majority of these are going to be almost irrelevant. However, we see so many of them now. Now, cysts in the pancreas can be either benign, completely benign, nothing to worry about. They can be cancer, or they can be precancerous, meaning that over time they will develop into a cancer. And there are certain features that we look at on these scans to see and look for features that are worrisome or high risk of this cyst becoming a cancer. So when we identify a lot of these high-risk features on this imaging, then we suggest trying to operate on these patients with pancreatic cysts that are high risk, because we want to get them out before it becomes a cancer. Now, having said that, the majority of the patients that come in, we identify with cysts, and they don't have any of these worrisome or high-risk features, and most of them will continue to follow. And many patients will have these cysts and they'll be completely stable for years sometimes. And we just follow them either once a year or once every couple of years to make sure there's no significant change in the cyst creating any of these other features. So if there are changes that occur, then we discuss trying to do surgery to remove it before it becomes a cancer. But in general, the majority of the times we just follow a lot of these cysts.
Thank you. Dr. Portelance, what specific research is happening at Sylvester in pancreas space?
What research in radiation therapy, is it what you said? Or what research in general?
In general.
In general. Well, Peter spoke earlier about the research that is being done on the systemic treatment side. And something that I find very, very promising, which is involving both a combination of radiation and systemic immunotherapy, is how could we combine those two modalities and enhance the effects of the immunotherapy at boosting the patients, the host immune response. So I think that this is very fascinating, and that once we start to unlock better the potential that there is behind that combination, we should make, good advancement in the management of patients with pancreatic cancer. More specific to radiation therapy, we've seen in the last decade the beginning of the use of a system called the MR-Linac radiation therapy. It is a system which is allowing us to increase the precision of radiation while decreasing the dose to the surrounding normal tissue. So better precision with better chances of controlling the tumor, and at the same time, less side effects on the normal tissue. So here at Sylvester Cancer Center, we teamed up with other large cancer centers in the United States, and even it was an international collaboration, and we published 2 weeks ago in a Journal of Radiation Oncology results of the first series of 150 patients treated with this MR-Linac technology. So precision medicine is key, and radiation is endorsing new technology, and we're privileged to have access to that technology here at Sylvester to help our pancreatic cancer patients.
Thank you, doctors, and thank you to all the panelists to help us explore this groundbreaking research and the effort to pancreatic cancer. It's really been an amazing hour. It's flown by. It has been a privilege to moderate the panel, this extraordinary talent and inspiration. Thank you to our experts for their tireless work and steadfast dedication to health solutions that continue to save lives. Thank you all for participating in tonight's town hall.